So as you know, PNH is an extremely rare disease, but patients with PNH do have significant complications which impairs their mortality and morbidity and affects the quality of life. So over the last 15 years, right from the first patients treated on clinical trials, we have had patients, the only approved treatment for PNH patients is eculizumab, which is given every 2 weekly. And the drug has got significant benefit because it improves their quality of life. In a proportion of patients, it stops them from getting transfusions, but more importantly, patients do not get the dreadful thromboembolic complications or thrombosis complications. So that's the background to it. So there has been significant development over the last 2 to 3 years on development of novel anti-complement therapies to see whether the newer anti-complement therapy, and one of them is the ALXN1210 or ravulizumab, which is being tested in this phase 3 trial, i.e. looking to see whether patients who are having it every 2 weekly, long-term, lifelong, whether they could switch to this drug, which is given every 8 weekly. So that significantly burdens the number of infusions they get, and so this trial was trying to look, comparing between eculizumab and ravulizumab to see whether the newer compound is non-inferior to ravulizumab. So the primary endpoint for this study was the percentage change in LDH, and there were 4 other secondary endpoints as well. One of them was to look at the breakthrough hemolysis, number 2 was to change in the FACIT-Fatigue score, and 3 was to look at transfusion avoidance, and 4 was to look at hemoglobin stabilization. And the study met all the primary and secondary endpoints, i.e. ravulizumab was shown to be non-inferior to eculizumab in this study. And with the safety, I don't think so there was significant safety concerns. There was no meningococcal meningitis in both the arms in the study, and the breakthrough hemolysis was not seen in the ravulizumab arm, while 5 patients had breakthrough hemolysis on the other arm, i.e. standard arm of eculizumab. I think this is sort of an exciting area at this moment because there is a plethora of complement inhibitors in the field which are going through phase 1, phase 2 and even phase 3 trials to see whether patients would benefit from different complement inhibitors in the setting of PNH, and they all have different mechanisms of action working on C3, C5 or different targets in the complement system, and more importantly different modalities of delivery as well: oral, intravenous, subcutaneous injection, self-administered, subcutaneous infusion. So I think that is very exciting period to be in, to see what can be done for these group of patients going forward. I think what this study has shown is that patients stable on eculizumab with a very good controlled LDH can be effectively switched over to ravulizumab, which is given every 8 weekly, and that is a significant, from the patient perspective, that's a big change, i.e. less infusions, better planning of daily activities, improvement, better quality of life because of all these things as well. And there is some emerging data from this study showing that we do get a deeper complement inhibition with not much variability in the serum C5 level, so that could be beneficial in the long term for patients as well. Yeah, so generally from the PNH perspective, I think there are a number of newer agents which has been tested in phase 1 and phase 2 trials. So some of the preliminary data has been presented in various meetings, but there has been updates coming from different companies and different compounds with, as indicated before, with variable modalities of action and delivery, which could turn out to be promising going down the line.